All right, well, thank you for joining us for our SIG for Patient Outcomes in Longitudinal Observational Studies, or POLOS. I'm Sebastian Bruera. I am a second-year rheumatology fellow at the Baylor College of Medicine in Houston, Texas. And so our agenda today is to review and update where we are in our SIG right now, which is what I will spend the next 15 minutes doing. We will also discuss identified domains and subdomains from a qualitative survey that we have done. We will discuss content and method issues, and then we will wrap up with the poll. Since 2018, we have had changes in our co-chairs. Our co-chairs are Dr. Lynn March, Dr. Loreto Carmona, and Dr. Maria Suarez Almazor. And we'd also like to thank our PRPs, along with our members, our previous trainees, and collaborators that have been able to make this possible. And so our special interest group, POLOS, was established in 2016 to identify, classify, and evaluate long-term domains relevant to patients that can be collected in a longitudinal observational studies with an emphasis on patient-centered outcomes. We initially decided to focus on rheumatoid arthritis. At this meeting in 2016, the decision was made to limit the scope to only large prospective cohorts or registries. So we did not include any administrative databases. Our patient partners were also engaged during this meeting, and we decided that activities such as work, social, or leisurely were considered to be crucially important for patients, even more so than survival. And so initial concerns that were brought up during this meeting is that OMERACT already has core sets for randomized controlled trials in rheumatoid arthritis. EULAR also released a core data set to support observational research and clinical care in rheumatoid arthritis that was published in 2017. And that there may be difficulties and burden in data collection process and difficulties in changing current processes by which registries collect data. And so the response to these concerns were that patient-centered outcomes may need a longer-term follow-up than what is typically needed for randomized controlled trials. Outcomes proposed previously were largely clinical versus patient-centered, and that they did not use OMERACT methodology to derive these core sets. And that the SIG should focus primarily on domains considered to be critical and follow a parsimonious approach. And so in our process for core domain set selection, we are currently on steps 8 and 9, which is to generate candidate domains in each core area, and then also prioritization of candidate domains through the consensus process and the Delphi. And this will be a large part of our discussion today throughout the SIG meeting. As an overview, I will discuss about what happened in OMERACT 2018. Here we presented the preliminary result of a systematic review that has since been published. The citation is below. We identified 88 registries and cohorts worldwide. We found that there was significant heterogeneity of outcomes that were collected and reported by these registries. But more importantly, we found that patient-centered outcomes are not consistently collected or reported. And so this is a table from that systematic review that looks at the frequency of patient-centered outcomes in the registries that we identified. We identified two types of registries: disease-based, which would have been rheumatoid arthritis, or therapy-based, which would have been RA patients on a betacept. And so each registry used various different types of measurements for patient-centered outcomes. And many registries did collect information on physical domains and symptom burden, but we did notice that many registries did not collect information on mental domains and social domains. And this is especially as important because in OMERACT 2016, with the help from our PRPs, we found that social domains and mental domains may be seen as almost as important as survival from a patient's perspective. So from 2018 till now, we conducted a qualitative survey, and we included patients with an ACR/EULAR 2010 diagnosis of rheumatoid arthritis and a disease duration for at least 5 years. In 2 of the centers in which we conducted the surveys, patients were also asked to identify and invite a caregiver. We had 36 participants, 29 of which were patients and 7 were caregivers. This table provides a description of the patients that participated. The majority were women with an age greater than 50 and a disease duration of less than 20 years. And patients participated in 3 continents: North America, South America, and Europe. Our survey consisted of structured interviews with open-ended questions that covered overall life/impact, symptoms, physical function, social function, work activities, and psychological well-being. Major areas addressed were derived from the review of the literature, feedback of initial SIG participants, and expert opinion of the working groups. Themes explored with some sample questions were overall life impact, which included questions such as what aspects of your life are most affected by RA, or how do you think your life may change in the future due to RA. We also explored symptoms and physical function, including what symptoms do you have because of your RA, or how do these impact your daily activities. We also asked about social function and participation, work and related activities, financial status, psychological well-being, and therapy concerns. Results were divided into the following core areas following OMERACT guidance. They were divided into disease manifestations and abnormalities, life impact, death/lifespan, societal/resources, and personal and environmental context. We did not categorize results into harms and benefits, as it was hard to tease out what was truly a harm and what was a benefit, as there was a lot of ambiguity and overlap between the two. So our first core area was disease manifestations and abnormalities. I've included some examples, but this is not a comprehensive list. The comprehensive list is attached to the reading materials. And so themes that we identified were symptoms with the sub-themes of pain, fatigue, anxiety, depression, stress. We also identified comorbidities and organ damage. Organs included joints, kidneys, heart, liver, stomach, skin. Comorbidities included infection, cancer, cardiovascular disease, reproductive issues such as fertility and pregnancy complications, consequences of surgery, and medication adverse effects. Life impact also identified the themes of mobility/ADL. This included complex activities as well as grooming, dressing, personal hygiene, sexual intercourse, and eating. Patients had also commented on the quality of performing these activities, such as slowness or clumsiness or dependency in being able to perform these activities. We also identified the themes of emotional/mental, which included negative emotions such as distress, stress, anxiety, mixed mood, or positive such as resilience, fighting attitudes, coping, or positive attitudes overall. In terms of the theme social participation, work was especially important among patients, especially work loss, absenteeism, poor performance, demotion, and problems with coworkers. Family, friends, leisure with social participation, and community were also especially important, with specific examples in the reading materials. We also identified self-participatory activities, which we separated from social, as these are usually done individually, and they included running, crafts/art, going out, and cooking. We also identified financial, such as loss of income, increasing costs, and again, the future concerns about ability to work. What we noticed from the life impact core areas was that there was an emphasis on complex activities. This included cooking, housework, shopping, and eating, whereas there was less emphasis on simple activities, such as lifting a cup or carrying a bag. There were also many statements on the quality of mobility, such as slowness or clumsiness or dependency to be able to perform certain tasks. Death/lifespan was also another theme. Was another core area in which the theme was mainly mortality, which was divided into the sub-themes of overall mortality, disease-specific mortality, and treatment-related mortality. The core areas of societal/resources included healthcare utilization, direct and indirect costs, which had the sub-themes of out-of-pocket expenses, costs of medical care, and other health needs. The core areas of personal and environmental context included the themes of personal, which included health, age, health literacy, self-efficacy, coping, adherence behaviors, personality drives, and the themes of environmental, which included health system, again, work, and social context, with the examples shown here. And so our next steps is discussion today to prepare the final survey, a discussion about the Delphi process to categorize domain and subdomain areas that are relevant to patients, and then voting. And that's it.
Okay, thank you everyone for joining our SIG today. So we are going to start with a question. Shauna, the first question can go on. This is just to identify yourself so we can know what group you belong to for today's meeting. I believe you can only check one. So check the one that best indicates who you are. Okay, great. I'm delighted to see we have so many patients joining today. Okay, so we are going to start the discussion. I have prepared some slides to keep us on time because we are so many and there are several things that we would like to discuss. So the way we're going to be doing this, I will bring the topics, and Loreto has very kindly agreed to monitor the chat so she can select your questions and then we can discuss according to the questions that you have with what I'm going to present. So let me open my file. Okay, here we go. Oops, my email open. And I'm going to share my screen with you. Okay, this is always a mystery to me. Do you guys can see my screen or?
Yep. Yeah, but you might want to go into presentation mode. So if you just click the little.
Yeah, it's not letting me do anything.
There you go, that one.
Yeah, but it's stuck. Ah!
Can you make it bigger, maybe?
It's stuck. I don't know what's happening. Let me.
We can see your mouse.
Yeah, but it's stuck. I mean, it doesn't even let me go to PowerPoint.
Sebastian, do you have the slides? You can just.
You did I send them to you, Bev?
Yeah, we.
Can you, if you have the discussion points, maybe you can put them in, and I'll just say next every time because it's frozen. I mean, it's very unfortunate because it worked perfectly. Oh, now it's moving. Let me see. But I mean, it's not even letting me close.
It looks like you're sharing your desktop, not the just the
Slide.
PowerPoint.
Yeah.
I would stop share and then just try to share the PowerPoint.
Okay. I mean, okay, I need to get off PowerPoint because it's frozen on me. Can someone else? I mean, I can start.
One sec. I'm just bringing it up. One sec.
Doesn't even want to quit. I'm completely frozen. I don't know what happened. I mean, it worked perfectly, but no, it's not. So, Bev, do you have it?
Yeah.
You just share it and put it on, and I'll say next every time. Okay, perfect. So we have several discussion points. Next. Okay, the first one, this is more than a discussion point. This is what was decided at the last conference call that we had, who would be the Delphi participants. So we decided that we would have PIs or corresponding authors from registries, and those were identified from the systematic review. So Sebastian went through all of those, and he has a list of people that we identified in that study. Then Loreto has the membership of the EULA Registries and Observational Studies, which is the group that did the original study that Sebastian showed in one of the first slides, where they were looking at what data should be collected in registries and prospective studies, but more from a clinical perspective rather than a patient-centered perspective, which is what we want to do now. And talking to Loreto, she really felt that what we are doing is beyond what that group did. So there's not a lot of overlap other than for some domains. And then, of course, the OMERACT membership, which includes patients, clinicians, researchers, industry, other stakeholders. Next. So one of the first issues that was discussed in these groups, and because we were trying to accommodate people from Europe and people from Australia, one of the things that happened is that we had two different groups, and sometimes the morning group and the evening group would not agree on what was best. So one of the issues was whether when we were including people from OMERACT in the survey, whether we would include everyone versus including just people who have some expertise with rheumatoid arthritis, either because they participate in research in some way, they have rheumatoid arthritis, or have family members who have rheumatoid arthritis. So then Loreto came with a question, and at the next SIG conference that was voted, and everyone, well, I think it was 9 people voted of the smaller group for this suggestion, and a couple did not. So this was to include a question at the beginning of the survey that would ask, do you participate or use research on long-term studies of rheumatoid arthritis, or do you live with the disease? So then if it was yes, they would participate in the survey. So again, that was decided by the smaller group, but I would be interested in hearing your thoughts and how you feel about this. So I'm Loreto, I don't know if anyone has put anything in.
Okay, we have a first comment by Diana on whether we should take into account all the different contextual factors already from the beginning on the participants. So that means dividing the patients into age categories already in the Delphi process.
Okay, that would require some amendments to the IRB that we currently have, because we didn't propose to ask specific questions from the participants that went beyond, I think, age and gender. But I don't think that I mean, there are many other contextual factors, and the respondents are not going to be just patients or not. I guess we will ask them to identify into one of the groups similar to what we had before. I mean, we could ask for more. I don't know if other groups have actually included questions that are more personal in nature about personal characteristics. I mean, we were just planning to include, you know, basic demographics and stakeholder group.
Martin is asking whether we are only recruiting RA patients, and that's the case, right? We are only recruiting RA patients.
RA patients or caregivers, you know, or people who live with others who have rheumatoid arthritis, who are familiar with the disease. That was the idea. And also to include the group of people who have, you know, some interest or work in some area of rheumatoid arthritis. But I mean, I'm open to ideas. I don't know. I know, I see there's another comment on the Delphi. We have that as a discussion point, so contextual, so maybe we can leave that for later on. But does anyone have any comments about this? Do you all agree? I mean, we will have this as a question in the poll at the end, so you'll be able to say what you think in voting, but no comments from anyone?
Doesn't seem
Loreto and Lynn, do you want to add anything at all?
Sorry.
Yeah.
Lynn.
Yeah, hi, thanks, Maria. I was thinking, you know, yes, I think we should have that as a screening question at the beginning, but should it necessarily preclude people from answering? Because we could then just sort of look at that in the analysis, because, you know, that even if they're a patient with a different disease, they might have some important points that they could add or contribute to, or, you know, so... yeah, and people who sort of research in other areas can still have an opinion on it. We could just look and see whether it makes a difference in the end, rather than sort of they log onto it and then they get that point and then they're thrown off it. So I think, yes, we should ask the question, but they could continue to fill in the Delphi if they wished.
Okay. Yeah, at the beginning I was also open, at least for inflammatory arthritis, right?
Yeah.
Courage says that it's important to have some relationship with RA to make meaningful contributions. That's what he says.
Yeah.
But I think if they have an inflammatory arthritis, it's still relevant. I mean, we're talking about flares, and flares are concomitant issue with PSA, with SPA, with all of our arthritises. So having a broader point of view might be quite helpful. We limited it initially with RA because we had the most data with longitudinal observational studies in RA.
Yeah, I agree. The other thing is whether we specify what long-term is. So maybe we should write something up front, right? Right, to say what we consider long-term.
Yeah, okay, but going back to the whether we include the array or not, if we include it as a question, that wouldn't, okay, when we poll you later on, the question says, I can't remember what the question says, because I've given those to Shona already, but we are referring whether it should be a filtering question or not, okay? That's what the question is asking, because we can always ask this question and not filter, okay? So when we poll you—
Do you, Marie, I can pull that question right now for you.
Okay. So that's the first question, yeah. So this would refer, do you agree with the screening filtering question for participants? Do you participate or use research on long-term studies of rheumatoid arthritis or live with the disease? So again, filtering.
So this is saying that they would be excluded if they answered this correct, if they answered this. Or they would bounce out, or they would be bounced out, or this would be a classifier.
And no, this would be to bounce them out, because a classifier we can always do, that's fine, okay? So by bounced out. But again, it doesn't have to be rheumatoid arthritis. We can refine that. The question here is whether we have some sort of filter to try to exclude people who don't have inflammatory arthritis or who might be researchers in an area that's not related to rheumatoid arthritis. So that's the idea, okay?
There are many more voices in the chat agreeing with the opening to inflammatory arthritis and also to researchers in other areas.
Okay, okay, let's assume that we don't have rheumatoid arthritis here, that we have inflammatory arthritis. Is this question really is trying to get to, should we filter or not, or just have it open to everyone within the OMERACT group? The others that we have selected, they are already researchers, you know, the registries and all of that in rheumatoid arthritis. But the question here is, should there be, and we can talk about this question.
It's confusing when you use the word filter, because that we could be filtering, so we would look at those who had RA versus everyone, but exclude is a different point. So we should say either inflammatory arthritis or only RA.
Okay, but if we say inflammatory arthritis or RA, who is in favor of selecting just people who say yes?
Okay, so we can put the question again, because people is asking in the chat to have it again with inflammatory arthritis if possible.
I also wonder, I mean, if it depends on who the questionnaire is going out to, if it's going out to OMERACtors versus OMERACtors and people who run registries, including, you know, and then the PRPs as well, wherever they may come from. Because I think the people who are involved in the OMERACT process may still be able to contribute from the perspective of what might be important from a long-term point of view, whereas, you know, unless they run a registry, everybody else may or may not, if they're not keyed into the OMERACT process, be able to do that. So it may be important.
Yeah, this would be primarily a question for OMERACtors, because the other ones, we already know that they are involved with rheumatoid arthritis in some way, because we took them from those listings, you know,
right,
papers, and so we know. So this would be for the OMERACtors. So it would be basically, if you say yes, you're saying, let's ask only the people that have inflammatory arthritis or live with the disease. And we can reword a little better. If you say no, that means everyone answers the Delphi and participates in the Delphi, whether they have inflammatory arthritis or no, okay? So yes means only select group of people participate. No means everyone participates. Okay, there is a question here. Why would you need to exclude someone? If they want to contribute, they must be somehow involved. So when we had the discussions originally, what was felt and was brought up is that if, let's say, I mean, and this is not going to happen because rheumatoid arthritis is a very, okay, good. So most people agree to screen. The issue is that rheumatoid arthritis is a common disease, so there would be enough RPRs or patients that would have rheumatoid arthritis. But you could get to a situation where, let's say, the majority of people could have maybe a different disease, you know, and then you are sort of drowning the voice of the rheumatoid arthritis patients because there are more people who have different diseases for whom some other areas might be more important or less important than what they would be for a rheumatoid arthritis patient. Just to give you an example, if you have patients with lupus, maybe mobility is not as relevant as it would be to a patient with rheumatoid. So there was a little bit of a concern that by being very open, some of the very important concerns that rheumatoid arthritis patients may have would get drowned by all of the other contributions.
Okay, so one thing that it's being proposed is to, right after they say they live with the disease, they specify what is the diagnosis.
Okay, but I think it would be even worse. I personally think, let's say if someone said, well, you know, I have whatever, you know, fibromyalgia, and then we say, well, that's not inflammatory arthritis. So you've answered all the Delphi, but we are not counting you. You know, I mean, I wouldn't want to do that. So that's why for me, it's a yes or no. We can analyze separately, but if we invite people, we need to say, well, you know, we consider.
No, once they say yes, they have an inflammatory arthritis, ask what they have. Yeah.
Okay, but yeah, you know, but I would be opposed to filter after and they have answered everything and then we don't use what they've said. I mean, that I wouldn't really like myself, but I mean, it seems though that most people would like to have some kind of filtering, okay? The filtering and the wording may not be exactly what we have, but we can work about that. Let me move on unless there's any, Loreto, I mean, I'm looking at the screen more than at the chat. Anything else on this topic or we move on?
No, we can move on. It's just, okay. Do not leave it like an open question, just with
next.
Mm-hmm. Sebastian, next, yep.
Yeah, thank you. Okay. Should all areas be included as identified by patients and caregivers in the first round, or should we attempt to lump? And if so, how? Again, this was an area of disagreement, and I'm going to call them morning and evening groups. When we brought this up and when we showed all of the areas that we had, which are, I mean, they are even more extensive than what we showed you, but they are in the materials that Sebastian referred to that are in the reading materials. You know, that's where we have all of the different themes that patients brought up. And some people felt that we should just go by what the patient said and put them in the first round, and whatever is not important or it's not perceived to be important would get out for the second round. But others felt that it was already too many and that we were kind of reinventing the wheel, because some of what we had as sub-themes within a theme, let's say physical function, for instance, were almost like what items in a questionnaire might be. So there was a little bit of a discussion on that, and then we thought we would bring it to the group to see what everyone thinks. No, don't put it yet. No, I want to discuss before they vote. Yeah. Anyone has any comments?
No, the only comments are from participants.
Let me see what
I think this depends a little bit on the number. I think if it's a large number of domains, it might be too many, and then it's better to lump them in advance.
Mm-hmm.
Yeah, can you give us a sense again of how many there were in terms of these potential things if you use everything that's there? Are we looking at 50? Are we looking at 70? Are we looking at 30?
Yeah, 70 more probably. Let me open, because I have that in let me see where I have all of that.
I think 70 is too much.
Yeah, core areas. Here we go. Okay, just to give you an example, okay, I'm going to read to you symptoms. So Sebastian had selected a few of the symptoms, but these are the symptoms that were identified, okay? Pain, fatigue, anxiety, depression, stress, stiffness, malaise, sleep disturbance, fever, appetite, nausea, headache, inflammation, cognitive fog, dry eyes, dry mouth, hair loss, bruising, genital dryness, low libido, okay? For instance. Then going to, let me see if I can find, I mean, mobility, there's a lot of stuff there. That's what has been taken care better in all of the longitudinal studies. But if we go, for instance, I mean, emotional, again, there's distress, stress, anxiety, mixed moods, sadness, anguish, loneliness, pessimism, despair, unhappiness, death ideation, suicidal ideation, anger, lack of enthusiasm, losing sense of humor, helplessness, self-image, appearance, inability to groom, dress as desire, and that referred more to not being able to use heels or have long hair. Others' perceptions, fear, future concerns about a number of different things. And then the positive ones, resilience, fighting, coping, positive attitude. So a lot of stuff.
It's long. Robin is asking whether we mean subdomains.
I call them sub-themes here, but it's subdomains, yeah. It's just that's the way I had it in the document. So there is a lot, but we felt that for this part, we would be more, you know, comprehensive. And Bing, I have to thank you for this, because our prior fellow, who was JB, well, maybe thank you or not thank you, I don't know. Our prior fellow, JB, had done it on his own, and he had, you know, he's a qualitative researcher, that's his area of study, so he felt that it was okay to do it on his own. But because you didn't think so, Loreto, Angeles, and I went back and, you know, read and categorize the transcript. So this is, you know, with double reading and with agreement among ourselves as to what the domains were, and anything that we felt was a little different, you know, because you could say, well, sadness and despair, I mean, is that the despair is a little different, but sadness as an unhappiness, is that the same construct? Well, I don't know that it's exactly the same construct. I mean, some of these are probably highly correlated and come together, but they all have a little bit of a difference. So we've been very comprehensive in what we have included in this list, okay? But again,
the experience from some of the other Delphis, though, is that you really do get into this diffusion, you know, of missing important things, because people are so split in terms of dividing their things. If you have 10 different things that are describing depression, somebody is going to vote on sadness, somebody's going to prioritize, you know, despair, someone's going to prioritize, you know, depression if you have that. And, you know, I would argue that those really do represent the same construct. And I really do have some fears about diffusion with too many things that are there.
Yeah, on the other hand, we have another comment from Grayson that says that maybe if we lump some things, we are not showing everything. So if we lump things where they do not belong, or where somebody is going to try to find them, maybe we are not going to get exactly the issues that matter.
And I can speak more to that as well.
Yeah.
Like to me, despair and depression are completely different things. They're similar. They're close together on a feelings wheel, right? But they are not the same thing. And so I think it is important to actually measure all of these things. Maybe not the vast majority, you know, maybe not include 70 things to measure, right? But it is important to be linguistically precise with these terms, because they mean different things to patients, even if they seem like they mean the same thing to providers. And it's really important, you know, to recognize that, and to keep in mind that if we're really wanting to gather accurate and useful data, that we're not going to get that if we're condensing language in a way that is only focused on maybe what providers are thinking these terms mean.
Yeah. So, so again, I mean, for us, we put them there if we felt there was a little bit of a difference, okay? And I agree that these might be different things. So Caroline here is saying that if we are lumping, who would make the decision? And that's why I have there, if we are to lump, who would do that? Something that I could perhaps propose is all of the patients that are participating in today's conference call, perhaps, I mean, if anyone does it, I would say it has to be the patient more than anyone else. Because for us, it's going to get into issues. I mean, it's very difficult for us, I think, to separate ourselves from the instruments that we know cover this or cover that, and from the feasibility issues. So I would rather have the patients lump it. I mean, it's not possible to go back and have the patients who did these interviews, because they are from all over, you know, from Italy, from Mexico. So it would be really difficult to do that. But I think, I mean, if we are to lump, I would rather have the patients tell us, you know, and say, well, these ones are similar and could be part of a single category. But again, I don't know how the group feels at large. Someone made a comment about sexuality. And that was very interesting, actually, because you could see that happen in very different ways. One was a symptom, you know, dryness or whatnot. The other one was mobility. So, you know, not being able to engage in sexual intercourse because of the problems with physical function. And the third one was everything. No, then there was, you know, not being interested, which was another, let's say, more mental symptom. And then the whole idea of intimacy and having problems with, you know, your partner. So again, that's an area that almost covered all the different core areas that we had. So what do you do? I mean, do you lump it just in one area, or do you have something that encompasses all of the different cores? So Loreto, do you think we are ready to vote?
Oh, there are, okay, there are other
Maria, it's 3:38, just wanted to point that out.
Yeah, thank you. So maybe we could do some factor analysis, Marisa says, and yeah, some people say that we can do data.
Okay, but to do factor analysis, we would have to have data, which we don't have.
Yeah, no, this will go later.
Okay, because, but right now, I guess my question is, because I really want to get this Delphi going. I mean, the general impression, and we are asking now, and we'll ask you to submit, but any more comments about, okay, Robin said here, I agree with data-driven lumping after first round. That's the other thing we could do, you know, and some people agree. So then before you answer, I don't know if some of you have answered already. So this refers to the first round, okay? And actually the question says that. It's not whether later on we're gonna lump or not. When we get to the second round, we can decide. But for the first round, do we leave the themes or sub-themes as they are, as we elicited them from patients, or do we attempt to lump? And then we can discuss later on how we would lump. That's before the first round. That's what we are asking, okay? Because we know that eventually we'll have to lump. And I mean the lump and maybe select, okay? Because that's the whole purpose of the Delphi exercise. So this is for the first round. So please vote. Okay, good. So 76 to 24. Okay, Bev, next one. Okay, I thought we had taken this one out because Lynn didn't like this particular question. But Lynn, do you want us to put it, Lynn, or not? We can take it out.
But you can put it in.
Okay.
It depends on the priorities. If we run out of time.
Okay, no, it's here, but we don't have a question. Yeah, we can put it here, but we don't. Oh no, go back, Beth. Sorry, I'm driving you crazy. Yeah, we took the question out, sorry, but I have it still as a discussion point. For some of these, it was really difficult to determine whether it could be related to the disease, the treatment, or to a prior coexisting comorbidity. And I think Phil Meese had asked something about fibromyalgia or pain, and whether we could be able to distinguish. Well, this is one of the areas where it would be very difficult to distinguish if pain was really caused by rheumatoid, or it could be caused by something else. And cardiovascular disease, I mean, it could be rheumatoid. It also could be something that they had before, or it could be, you know, they are on steroids, or a number of things. So should we make any attempt at all to categorize by potential cause? And again, we may be able to do it later on, but for the purpose of the Delphi, should we even attempt to say these are treatment-related subdomains or something like that? And I didn't put it as a question for the poll, but if you have any comments, that would be good.
So this is Phil Neese. My question was partly just simply to encourage you to make sure that you include fibro/central sensitization as on the comorbidity list. Because for the obvious reason that it's an important contextual factor. And if a third of the patients have concomitant inflammatory arthritis and central and an elevated levels of central sensitization, we need to know that.
Yeah.
And increasingly, patients know that as well. Many will not, but they will have had a discussion about it with their clinician. They may have filled out a questionnaire, PRO, that like a widespread pain index that helps understand that, and it impacts their ultimate response.
Yeah, I think one of the reasons why this was not here is because what we have here doesn't include expert opinion such as yours. This is coming just from the interviews from patients. So there was no instance where they referred to pain caused by fibromyalgia. That was not something that was brought up in the interviews. So that's why it's not there. But I mean, that's where we are looking also for anything that you can add, either now on the chat or email us at a later point of things that are missing and you think are important because they just were not brought up in the interview. Okay.
Yeah, so, I think we need to move on. Most people is just saying that it's very difficult to define where they can.
Okay, then the content of the survey, again, for the first round, we put everything, but something that was really very interesting to me is that patients don't really talk in terms of small little tasks when they talk about things that really matter to them. It's these complex activities, okay? And when you look at some of the questionnaires that look at physical function, they tend to go for the little activities and the little tasks and not for the big ones. So, you know, carry a grocery bag versus shopping. So people don't say necessarily, I can't carry the grocery bag. You know, they will say, I can't go shopping for groceries. Or they will say, I have difficulty eating, but they don't say, you know, I can't grab a glass. So again, should we make some attempt to try, and this would be part of whether we put absolutely everything or we kind of lump, and I guess we went for putting absolutely everything, but if you have any comments about this, whether we should try to have more emphasis in these more complex activities. Because at the end of the day, we are talking about long-term rheumatoid arthritis, not about a clinical trial, whether 3 months later you weren't able to lift a cup and now you can. I mean, after 15 years of disease, what you care about is can you go and buy groceries? So what do you think? Here are there any comments, Loreto, from someone?
Well, from Annette, it says that she has answered that 5 pounds bag of sugar question for like 30 years. Yeah, but.
Yeah.
I was just going to mention too, I don't have the whole list in front of me, Maria, but I know that at the ACR just this last week, and there was a lot on diversity and social equity and making sure that all of these questions were relatable to people around the world. Like they used bags of sugar, for example. People don't necessarily use bags of sugar, or pouring a milk carton. People don't always use that. So I just would like to revisit those two. That's just a little side note, but if we're moving forward, just to make sure that we're being correct on that.
That's also, I think, a point that indicates that complex activities are a better measure, because you say shopping in whatever way you shop, whether you go by car or you go walking, it's not talking about that. It's talking about the full complex activity that you engage into. I mean, for physical function, I understand that in the context of a trial, you want very precise measurements. So it's much easier to measure. I mean, it's a subjective measure, but whether you can lift a cup, than say, you know, the shopping that has so many other tasks involved in. But this is a little different. So anyway, we only have like 15 minutes. I think we're going to be okay because we were voting in between. But this was the question that we had. If you would like to vote.
Yeah, well, why people is voting correct says that complex activities also lump things together because there may be certain aspects of shopping that makes the whole experience difficult that can be missed. So it's a way to measure all those complex things and also equity and all that. And then Lynn says that lumping, but providing examples that are more diverse.
Okay, we can copy all the chat so we don't lose
Yeah.
anything, correct?
Yeah.
If someone will do that, given that I have all of these IT issues.
I'm doing it, Dr. Suarez.
Yeah, you are. Thank you, Angeles. You always save me. Okay, great. 67% say complex is more important. Okay, next one. Okay, there was certain overlap across domains. So for instance, depression, is that a symptom or is it more life impact in the mental domain or psychosocial domain? Coping, is that an outcome? You've learned to cope because you have a disease or a positive outcome, or is this contextual? This is your personality and this is who you are. Mortality, there's overall mortality, disease specific, treatment related mortality. And Robin, you may want to jump in and say, no, treatment related, we shouldn't include that. But it's very important for patients. Patients want to know, you know, is this something that can kill me? You know, this treatment, is there mortality associated with that? So I personally think that it should be separated to some degree because patients want it. I understand there are methodological issues because it's very difficult to just distinguish something and say this is just treatment related versus this is just disease specific. Okay. But anyway, again, that I have these examples on depression, coping, but I gave you another example on sexual function before, how it's physical, but it's also, you know, psychological and all of that. And this relates to the Delphi, okay? When we do the Delphi, should we make an attempt to include these ones just in under one theme or one core area, or should we repeat them if they belong to more than one core area? Or we should get rid of core area and just put words in there. What are your thoughts about that?
I think in the first round you should use words because depression can be a symptom. For others, it can be life impact. And for others, it can be a comorbidity. It can be a set diagnosis. So it highly depends on the way that it has been described by patients, where the emphasis lay.
Okay, so I'm going to play devil's advocate and ask you a question. But what if we take it out in the first round? And this is not something that I have made my mind, that I have my mind set about. But you know, I was thinking about the difficulty. So let's say we take it out and we put it just, you know, in with the words. Then we don't know how they rated it. If they rated it as a symptom or as a life impact. So when it comes at the end, a time to put it back in the box where it belongs, we wouldn't know what box it belongs, I guess. And I don't know if that's important or not. Maybe we don't care.
Yeah, I don't have an answer to that, but you might want in the second or third round, if it rates very high, then we could ask the participants again. Depression has been a high priority. What is it for you? Is it a symptom? Is it a life impact? Or is it a comorbidity? So that the patients indicate how they interpreted this domain.
Yeah, Robin is saying also to fix it later. So matching it with core areas subsequently, but use the words in the first.
Okay, well, we have a question though, Paul question. So about this, next question.
Sorry, there's two. So is it the one that says, given that there is some overlap, should domain subdomains be included? Yep, okay.
Yeah.
So that's up for everybody to vote now. So it says, given that there are some overlap, should domains, subdomains be included in the first Delphi round under core areas? So option 1 is yes, it makes it easier to think about them. 2, no, better to list them without categorization as there's too much overlap. Or option 3, no opinion, leave it to the co-chairs.
Okay, list them without categorization. So the next question read, if we categorize domains under core area, should we include overlapping domains more than once? But I guess most of you have said that you wouldn't want to categorize them. So I don't know. I mean, if you want, you can answer it just in case at the end we decided to categorize for some reason, but I think most people don't want to categorize. So, I mean, I'll read the question. If we categorize domain under core areas, should we include overlapping domains more than one? So, for instance, depression. Yes, I might change my mind based on where I see it. No, repetition annoys me. No, opinion, leave it to the co-chairs. Okay, so this is interesting because most of you voted before that you didn't want it categorized, but now you're saying that you want it in every single category. So we don't have to think about it. Okay, I guess now you realize, well, maybe it makes some sense to have it in categories. Any comments about that?
It's probably how you ask.
Yeah, okay. That's good. Someone didn't get vote?
No, yeah, some people didn't vote on this because they didn't want to categorize. Yeah.
Okay, so you really wanted to talk about contextual factors. Everyone was putting things in the chat. I mean, the little I could read while I was talking, I could see that contextual factors was a very important issue. I mean, we've been talking about it a little bit ourselves, and we think it's very important, of course, very, very important. Especially in long-term studies, you may want to have some baseline variables that relate to contextual factors. But because, I mean, there are some difficulties and you have pointed them out, there's overlap with what is an outcome versus what is a contextual and all of that. So for instance, Martin is talking about coping can be both. So, I mean, we could include that in an outcome and not do the contextual. One of the thoughts we had is that because contextual, it's going to be so, you know, important, and there is already a contextual group, which unfortunately is happening tomorrow. I would have liked for it to happen before this one, but that perhaps we can do the contextual factors at a later stage with a different survey. So it's not, I mean, and I didn't know how this was going to go, if you guys wanted just the raw words or you wanted more of a lumping, but given that everyone wants the huge survey, one of the things that we could do is leave contextual for after we've done the other course. What do you people think? Any comments about that?
No, we're still on the previous question on why it's important to categorize.
Yeah. Okay, so this is the question about contextual. Okay. Whether, and we are talking about first round. Okay, so again, that we are not saying not to measure contextual. We all agree it's hyper important. Okay, what we are saying is, not in this first round of Delphi, maybe later on in another round, or after this Delphi, you know, another time later on, because of the limitations in how huge this is, and also the fact that we hadn't had the contextual SIG yet, and that there are issues with overlap and so forth. So that's one of the things that we were wondering. So maybe you can vote. Should we include contextual factors in this initial first round of Delphi? Thank you. Let's work for us. Thank you. This is a question that I've liked the best of all. Yeah, because it's too complex. I mean, I think for now, we need to get, yeah, very important, but I really want to work. I mean, I think we need to work with Robin and company on this to do really a good job rather than reinventing the wheel. Then I don't have a question for this, but there's other issues. We only have 3 minutes, but I welcome your thoughts. Societal and resources, I mean, because this is patient-centered, it was, you know, primarily things that relate to out-of-pocket. I don't know if it would be important to include them. Some of it is going to come up with financial. So my idea was that societal resources is a broader topic altogether, and that, you know, direct, indirect costs, all of that. I mean, we can't really force registries to collect that data if we're saying we are patient-centered, because that goes beyond patient-centeredness, I think. And then the other idea that we had is that for the last round, and we only have 2 minutes, so I welcome your thoughts either now or by email. There are questions that relate specifically to the conduct of a long-term study or a registry that are not as pertinent for a clinical trial where you measure everything at given points. And that would be if you agree that in the last round, we may ask some other questions of respondents that are a little different. So for instance, would be, what do you think that the questions that we ask should refer to today, to the past week, or to the past month? So if we're asking depression. So again, it's not that we want to do it now, but whether you agree that asking these sort of questions that will relate more to how we choose instruments at the end. So it's not domain, but just to take advantage of the Delphi asking those things, and also the frequency of administration for these domains. This is not a trial, so it really wouldn't be appropriate to ask for these questions every 3 months or every 6 weeks. It would be like more like once a year or so, but asking that in the Delphi. So again, I don't have that as a question in the poll, but I would, okay, I can see yes and agree, so that's great. So it's 2:59. I want to thank everyone so much for participating. Loreto and Lynn can have the last word since I've talked so much.
It's been a pleasure. It's been very difficult to put all this information together, and thank you so much for reading everything.
Yeah, congratulations all, fantastic.